Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Professor Dr. Sorry, sir. Just a moment. Yes, a very renowned doctor, Dr. Kuresh B. Maskati. Sir is the MBBS. Hello, sir. Am I audible to you?
Perfect.
Yes, sir. Sir is MBBS, MS, DOMS, FCPS, FICP consultant at Muscati Eye Clinic, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is cornea transplant, natural and artificial. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you, Shreyan. And I'm happy to be back with you at the IJCP sessions. It's always a pleasure. The interactiveness especially appeals to me. So today we are discussing corneas and their transplant. When can you do a human natural cornea? When do you need an artificial cornea? And if possible, we'll try and see some videos of both the procedures, the natural and the artificial. So without further ado, can I have my slides? So this is what we will be discussing. I am based in Mumbai at Muscati Eye Clinic, and so let's start with some basic questions. Uh, is the whole eye used for transplant? What exactly is transplant? Because people use terms like eye transplant and cornea transplant very loosely. So it's not the whole eyeball, obviously, but it's only the thin transparent layer in front of the eye called the cornea, which is used for transplant to replace the diseased or opaque cornea in the eye of the patient. So typically you see that picture of the opaque cornea, and then it's replaced by a clear natural graft from a person who has donated eyes after death. Corneal transplants is done from donors only after death, unlike kidney, liver, and other transplants where you can take it from a living related donor. In cornea, that is forbidden. It's only in Hindi movies. So it's only removed after the death of person and the relatives donate the cornea. So, does the human body reject the transplanted donor cornea? Why are we talking about artificial? How successful are natural corneal transplants? Human cornea does not have any blood supply. So, unlike again the kidney and the liver, the blood vessels there come and attack it. You have to use immunosuppressants. Here, the risk of rejection is very low. Rejection, if it does occur, can be suppressed by timely medication. In general, the chances of success are greater than 80%. You can see the slide, the picture there of 2 years after surgery, crystal clear cornea. That the triangle like a ceiling fan is an artifact. And in the other picture, 20 years after surgery, where you can't make out a cornea has been transplanted. So this is a very, very highly successful procedure at most times, provided the indication is correct. So, of course, corneal transplants don't guarantee sight to all blind people, but I need to stress this because people forget when I tell them there is a wonderful, successful mechanism, they feel it can be given for all blind people. So, in the patient that you see where I put a tick mark, where the whole cornea is opaque, yes, you can replace it with a natural cornea and restore eyesight. So also in the middle picture where the central cornea is opaque, rest is clear, but the central cornea is hiding the pupil through which light goes in. So the patient has very poor vision. Yes, I can do a small corneal transplant only in the center and restore sight. But in the third picture, that's a picture of the retina, which is taken through a fundus camera or a retinal camera. And what you see behind is a chalky white or very pale optic nerve. So that's optic atrophy. So this patient has lost vision because the nerve is dead. Just like when the heart is dead, you can't revive it with a heart transplant. If the nerve is dead, we don't have nerve transplants. So we can only do cornea transplants. We can't do nerve or retina transplants as of today. So, what is new in corneal transplants? I'm still sticking to the natural cornea because that is the best form of corneal transplant. Previously, we used to do only what is called full thickness transplant, as you can see the picture there. The central cornea disc, the entire disc, our cornea has got multiple layers, as you can see in the picture above, where there is cornea has got multiple layers. It's a thick structure with the inner lining called endothelium, and the middle two-thirds or three-fourths of the cornea called stroma, and the upper lining called epithelium. So there's epithelium on top, stroma in between, and a thin inner lining called the endothelium. So we used to transplant the whole cornea, as you can see in the picture, which says full thickness corneal transplant, irrespective of whether the superficial part was damaged or the inner lining was damaged. We had no choice. So you can see the picture where the full thickness of the cornea is transplanted. But nowadays, with better equipment, better technology, and better knowledge, if only the front portion of the cornea is damaged and the inner lining or endothelium is okay, we do what is called a lamellar corneal transplant. That means we transplant only the front layers. If similarly, if the inner lining is damaged, the endothelium is damaged, we transplant only, we remove that endothelium and transplant a new endothelium. So this is new the procedure which has come in. It's called lamellar keratoplasty, and you can see on top that the two names, DSEC and DMEC. DSEC means the inner lining is transplanted. If it is automated, so it is deep endothelial transplant, and if it is by use of an automated machine called a keratome, then it's A comes in. Otherwise, we call it DSEK. So that is the inner lining which is transplanted. That the innermost part of the stroma and the endothelium. But if we transplant only the endothelium with the decimase membrane, that's called DMEC. So these are two procedures which we call posterior lamellar transplants, or the inner lining is transplanted. And as I told you earlier, if the front portion is damaged, like in keratoconus, the cornea is bulging forward, but the inner lining is okay. So we do what is called an anterior lamellar transplant. If it's a deep anterior lamellar transplant or deep anterior lamellar keratoplasty, we call it DALK. So in theory, one cornea donated can be used for two patients. One patient can have a DALK and the other patient can have a DSEC or a DMEC. So if one person dies and donates two corneas, they can be used to restore sight to 4 blind patients. So we'll go through the videos a little later. So we'll see the video of penetrating keratoplasty of full thickness cornea, then the video of deep anterior lamellar keratoplasty, and a video of the posterior lamellar graft as well. Let's move on. So these are all patients in whom a natural cornea can be done. But there are some patients in whom a natural cornea cannot be done or will not be successful. In them, we use what is called an artificial cornea or a K-Pro or a keratoprosthesis. So K-Pro or keratoprosthesis is used. There are many different types of K-Pro in the market. The ones most widely used was one which was made in India called the Singh Wurst Champagne Cork K-Pro. We won't talk about it in the interest of time because it's done only by in a couple of centers in India. Then there is the MOOKP, or the modified osteoodontokeratoprosthesis, which uses a tooth and we put a plastic cylinder inside a tooth which we extract and put the tooth in the eye. It's a complicated procedure, sometimes requiring 2 or 3 stages. And the other one is the Pintucci keratoprosthesis, which I do. So we'll see pictures of these. It has a Dacron mesh skirt haptic and artificial plastic cylinder which is there. You can see in the bottom picture that plastic cylinder pokes out of the eye. And the commonest procedure done worldwide is the Dolman or the Boston keratoprosthesis, which cosmetically is also a little more appealing. So let's see what is the difference between a natural cornea and an artificial cornea. So a cornea is opaque. Should I offer it a keratoprosthesis? No. Corneal transplant gives very good results in a majority of cases, both the lamellar and the full thickness grafts. You can see the picture with 25 years post PK. PK means penetrating keratoplasty of full thickness. Crystal clear. The edges are white that you could see because we have done only the central area. Through that, you can see the iris, the brown portion, the pupil, which is in the and the lens behind. So 25 years after a keratoplasty, still crystal clear. And if there is a corneal infection or a corneal abscess, you can't do a K-Pro. You have to do a natural cornea. So very large diameter, a therapeutic penetrating keratoplasty. TH stands for therapeutic. So 11 millimeters is the diameter of the cornea. So the whole cornea was diseased, was had pus, had an abscess. So it was removed and a new cornea was put in. So that's a therapeutic keratoplasty. So in the presence of infection or pus, you can't put an artificial cornea. So the advantage of putting a natural cornea is that the field of vision is like yours and mine. It's a wide field of vision, while in a keratoprosthesis, the field of vision is restricted to 30 or 40 degrees. So you can see that bottom picture is a successful corneal transplant. So corneal transplants, natural cornea is the way to go. Only when the cornea is vascularized, or so we need to know, then why would we do a Boston K-Pro? So a vascularized cornea, if the cornea has got blood vessels on it, then as I told you, the body will recognize an intruder and the body will send white blood cells to attack it and the graft will get rejected. If a graft has already been done, a natural cornea, sometimes once, twice, three times, four times, and it's been rejected every time, then the body is not willing to accept the graft, then you're better off putting an artificial cornea. So if there is a stem cell deficiency, around the cornea is the area where the stem cells of the cornea reside. If the stem cells are deficient, then the epithelium cover will not be formed. So any graft will get rejected. So in cases where there is stem cell deficiency, like in chemical burns, acid or alkali burns, or patients born with stem cell deficiency, you need to do an artificial cornea if there is opacity. Of course, the eye must have good visual potential. There must be no optic atrophy, which I showed you a picture behind, no glaucoma. The posterior segment, the back portion must be fine. The anterior segment should not be severely disfigured. And in a Boston K-Pro, there should be good tear secretion. The lids should be able to blink up and down well, and the lids should oppose each other well. These are the cases in which if you can't do a natural cornea, you can do a Boston K-Pro or an artificial cornea. So which patients should not be referred for Boston K-Pro? So we've told you which patients should not get a natural cornea, but they should get a Boston K-Pro. But if a patient has poor tear secretion, or those in whom the cornea is keratinized, there is a keratin layer on top, as you can see in the picture on the left, and those with a history of previous corneal melts, because in a Boston K-Pro, you need a natural cornea, and in the middle of that, you put the plastic cylinder. So if there is a history of previous corneal melts, like immune conditions, then the natural cornea will melt away and the artificial cornea will fall off. Those with poor lid blinks, like the patient below, if his blink is not there, then the eye dries up, and again this cornea will not work. Or if the lids are not opposed well to each other, then you can't do a Boston K-Pro. So what are the contraindications for all K-Pros? If a patient is unable to follow up with some eye doctor, because they need constant follow-up, every 2 to 3 months they must come to an eye doctor, not necessarily to me, but to any eye doctor in their village, town. If they don't have that facility, or they're unable to travel to an eye doctor, it's better not to do a K-Pro. Then all these patients need eye drops for life. Antibiotic drops should be continued for life in K-Pro. So if the patient is unable to follow this treatment regime, or they're not intelligent enough to comply with my instructions, it is better not to do a K-Pro. And of course, the third one is a relative contraindication, because I'm in private practice. So I'll show you some of the pictures of successful K-Pro. So the first picture you see is chemical burns where the whole cornea is opaque. You can see the blood vessels growing on the cornea. So natural cornea would not work. This is the same patient in the middle picture on the top, post-operatively with the Boston K-Pro there. Incidentally, Boston K-Pros are also made under license in India, and they're called Oro K-Pro in India, and perfect, excellent quality. So it's the same patient in whom I have done a corneal transplant around, and in the center of that I've put this plastic cylinder which is staying very well. And the third eye is a different patient with chemical burns again, where the post-operative vision is 6 by 6 or 20/20 or normal vision. Another picture below, the Boston K-Pro with the sutures still there. So the natural cornea has been sutured, the sutures are still present, and in the middle is the plastic cylinder. And the middle picture is of a lady in whom I've done the K-Pro, and this is the first day post-op, little bit of redness, but the cosmetic appearance is not bad. And the last picture is Boston K-Pro with the sutures having been removed. So blood vessels have grown in, which doesn't matter. The natural cornea has become opaque, which doesn't matter, because the patient is seeing through the artificial cornea, which is what you're seeing as a black portion, which is actually a transparent portion through which you're seeing through the pupil. So such patients, this is the appearance, and they can have 6 by 6 or normal vision. So how do we evaluate the patient? This is Dr. Tony Aldave or Dr. Anthony Aldave, who taught me this procedure way back in 2009. It's been 15 years now since I've been doing this procedure amongst a handful of people in the country. So we check the history, we check the visual acuity. Patient should have at least good perception and projection of light. If he doesn't have that light projection perception, that means there's something wrong with the retina optic nerve. Better not to do this. We check the intraocular pressure. If it is raised, it could be glaucoma. I might combine the surgery with glaucoma surgery at the same time. Then we evaluate the blink mechanism. I ask the patient to blink. I evaluate the tear secretion, whether it is normal. If not, I will not do this. I look at the patient on slit lamp to see whether he is phakic. That means the natural crystalline lens is there. If it is there, I have to remove it to make place for the artificial cornea. If it is pseudophakic, that means if there is a lens implant inside, if the lens implant is sitting well, I won't disturb it. Otherwise, I will make the patient aphakic. That means I will remove his crystalline lens. Then I look at the optic nerve using an ophthalmoscope to see whether there is any cupping. Is the macula okay? If I can see it, fine. Otherwise, I will do a sonography to find out. And if it is deep cupping, optic atrophy, I will not do this. If there is retinal detachment, again on B scan or sonography, we will not do it. And all of them will require an A scan, that is an axial length measurement, because we have to send this to the manufacturer to supply us the appropriate power of in the K-Pro. So these are the parts of the Boston K-Pro. On the top is, as you can see, this is what will project out towards the sky or towards the outside world. It's mushroom shape. It's made of PMMA. This is the front part. Then, as I said, we take a natural human cornea from a donor from the eye bank. We drill a hole in it, 3.5 millimeter hole in that. In that, we place this front portion of the cylinder, and then we put a back plate which has got 16 holes in it, so that it allows the aqueous humor to flow through. And the back plate gets screwed on to the PMMA front portion which is there, and with the cushioning of the corneal graft. And lastly, we put this titanium ring. It's a metal ring with like a bangni, like a bangle, which has got a small gap through which shuts very tightly so that the whole thing gets well assembled. I'll show you the assembly in a video. So the ideal cases are those which are one or more failed grafts with poor prognosis for further grafting. Vision should be less than 3 by 60, means poor vision, with similar, ideally poor vision in the other eye. So usually we choose one-eyed patients because it's a surgery of last resort, and patients should have no end-stage glaucoma or retinal detachment. And as I told you, the last one is a relative contraindication, but patients should be able to afford the cost and should be compliant for follow-ups. So this is my first, I'm sharing with you my first patients done since 2009. I've done over 50 cases in the last 5 years. But this was a patient I selected with a divergent squint, thinking that he may be amblyopic. Even if I fail, it will be all right. But to my surprise, he got 6 by 12 post-op in spite of the divergent squint. And this was another patient, a young girl, who got post-op 6 by 18. Though she had history of corneal melts, ideally I should not have done this, but the other eye was optic atrophy, so she had only one eye. It's now 15 years down the line. She's happily married, and she was 15 years old at that time. And in spite of corneal melts, we've been treating it with immunosuppressives, with methotrexate, and we managed to preserve her vision. I'll try and show you this video, and will this is the Pintucci keratoprosthesis. I did this patient in Malaysia where he had acid attack, and after 18 previous procedures done in his eyes, I restored sight with a different keratoprosthesis called the Pintucci keratoprosthesis. Boston keratoprosthesis done in one sitting, while the Pintucci requires 2 sittings to do. So that is a totally, this can be done in bilaterally blind patients, and it can be done in patients who got keratinization, who have got bone dry eye. Even in them, we can do this Pintucci keratoprosthesis. So this is where you can't do a Boston K-Pro, you can do a Pintucci K-Pro or a modified OOKP, but there you need a tooth, which we don't like to use. So the visual results in my hands, we've been doing it since 1997. I've done about 75 odd cases and no improvement in vision in 12. The cosmetic appearance is not so good, but the visual, many of them got back working vision. They could go to the toilet, they could eat their food by themselves. This is a patient above with 5 years post-operative, and this is 10 years post-operative results. So conclusion is that though natural corneal transplant gives excellent results in cases like stem cell deficiency or vascularized corneas, where a corneal transplant natural will not work, we have the choice of doing artificial cornea keratoprosthesis surgery with a good success rate. If the tears are good and if there is no keratinization, I would do the Boston K-Pro. And if the tears are not good, it's a dry eye and there is keratinization, I would do the Pintucci keratoprosthesis and give good success rates in selected cases. I thank you so much for your attention. And before we close off, Sriyan, I'd like to try and show the videos if it's possible. Can I?
Yes, sir. You can share your screen. So there is an option called present below your screen. You need to click on it again.
Uh, Option
Called present.
present. Yeah. Okay.
Yeah. Please click on it. Then there is an
Share
option
screen.
called share screen. Yeah.
Yeah.
There you need
Then
to select that entire screen option.
entire screen option. Yes.
Yes. Select that screen, sir, and click on share.
Okay.
Yes, sir.
Okay.
Your screen is visible now. I'm adding it to the screen. Yes, sir. Now you can go to that video and play it.
Okay. What has happened?
So you have
I've
clicked
done
on the
something wrong.
full screen. You have clicked the full screen option. So just click on
Exit full
escape.
screen.
Yes, sir.
Okay. Now.
Now, sir, the videos where you have saved it now, which you
Yeah.
want to play, you need to click on that video. Not this is the StreamYard tab you're finding it on. So just
Okay.
go
Okay.
back to that presentation tab.
Okay.
Yes, yes, sir.
Okay. Uh, yeah. Can you see the video?
Yes, sir. Your video is visible.
Yeah, so this is the patient who had corneal graft done, and it's a failed corneal graft. So I'll just show you how the Boston K-Pro is assembled. So this is the trephination of the recipient cornea, and this is how it's. This is the donor cornea, which is trephined, and then I will remove this donor cornea, so and put it on a sticky tape and make a 3.5 millimeter hole in it with a punch. So this is a 3.5 millimeter hole which is punched out. Now it's put on that mushroom shape which I told you about, and some viscous material is put. Now the back plate is put. This has got 8 holes. The newer ones have got 16 holes. The back plate is put uh, on that cornea, and that thing is projecting. That plastic is projecting. This is the titanium ring which is put there and pressed into place, and now it is ready to be transplanted. Yeah, so then afterwards we just remove this cornea and put that whole assembly there and suture it into place. So this is the Boston K-Pro. I'll just show you the full thickness corneal graft. So this is again the round metal ring is the Fleringer ring which we use to keep the eyeball in place. So this is the whole cornea. So the full thickness of the cornea is going to be cut in the center, putting some viscoelastic, some air bubbles inside, and we cut the whole thickness of the cornea. So this is the whole thickness of the cornea is being cut. There is an intraocular lens implant inside. So this is the full thickness which is cut. The lens implant was a broken lens implant, so I'm breaking it further and removing it. I'm replacing it with another lens implant. First, I'm making an opening because the pupil was all closed over here. There was some cataract material still there. The previous surgeon had not done a good job of cataract surgery. So I'm removing all the remaining cataract material, making a big hole in the pupil. And this is an anterior chamber lens which I'm putting inside the eye. And this is the full thickness cornea which I'm putting there. And this is sutured into place. So this is called a full thickness corneal graft. Now I'll show you a front portion of the eye, what is called a deep anterior lamellar keratoplasty. So here only the front portion of the cornea is damaged. So I'm not cutting it fully. I'm dissecting it layer by layer. I'm putting an air bubble inside to separate the layers. With a sharp knife, I'm cutting it and cutting very gently. This is a more difficult procedure. So we're cutting off layers of the cornea. I've put an air bubble in the anterior chamber to guide me. So we're cutting layer by layer. There are air bubbles to help me. So this takes a little more time because you have to be gentle not to perforate. If you perforate the cornea, then you have to convert to a full thickness corneal graft. So I'm removing the segments of stroma that you can see. This is the stroma that I'm removing layer by layer. Finally, all the stroma is removed. Now from the donor cornea, I remove the inner lining and then apply the donor because I'm using the patient's own inner lining and I suture it into place. And the last I'll show you is a desec, which I'm doing only the inner layer. So this is an artificial anterior chamber. I'm going to remove the upper layer and I'm going to use only the inner layer. So I'm dissecting out the upper layer. This is an artificial anterior chamber and here only the inner layer was damaged. So I am just marking to know how much. So I'm going to go in with an instrument and scrape out the inner lining. I'm putting in what is called an artificial anterior chamber maintainer. And now I'm going in with a blunt instrument and I'm scraping the inner lining of the cornea. Then I'm making a small incision and I'm going to remove that inner lining. And here this is the donor cornea. I've taken out only the inner lining of the donor cornea and now I'm replacing it. I pushed it back, put an air bubble into place. So these are the various facets of corneal surgery, both real and artificial. Thank you so much for your attention.
Thank you so much, sir, for your wonderful presentation. Sir, we do have some questions from our audience if you'd like to take that up.
Sure.
Thank you, sir. So, sir, the first question from our audience is, what
Can
are
you
the
see me? I can't see myself.
yes, sir, you are actually, sir, you need to stop sharing the screen actually.
Okay. Uh, where is that? No.
So
Okay, it
you are
doesn't matter.
visible.
I'm visible. Go ahead and ask me the questions.
Sure, sir. So, sir, the first question is, what are the primary indications for cornea transplantation?
In our country, the primary indications are usually injury or infections, because we get a lot of children with bow and arrow injuries, children with play with sharp objects at home when the parents don't look at them, and they get injured and they get corneal scar, or they have vitamin A deficiency and the cornea becomes opaque, or you have injuries caused by surgeons while doing cataract surgery, so the inner lining gets damaged of the cornea, or you have a condition called keratoconus, which affects one in about 5,000 people where the cornea is conical. Then we do only a deep anterior lamellar keratoplasty. So these are some of the indications for corneal grafts. But most important is infections, especially in the rural areas where hygiene is not so good. The cornea gets an abscess, so then we have to change the cornea, put a therapeutic penetrating keratoplasty, and then that can become opaque because you do it in the presence of pus, and then maybe 6 months later we can do an optical keratoplasty to restore sight. Thank you.
Thank you, sir. The next question from our audience is, how have these advancements impact surgical outcome and patient recovery?
Oh, the advances are huge. First of all, 40 years ago when I was studying, we didn't even have 10 or nylon sutures. So the sutures were quite thick. So it used to excite vascularization. Now the sutures are very fine, 10-0 and 11-0 nylon, which is very, very fine, much thinner than a human hair thickness. And with the advent of newer techniques, we change only those layers which are affected. So the chances of rejection becomes even less. And in the small percentage where we can't do a natural cornea, as I explained, artificial corneas can be done to restore sight. Thank you.
Thank you, sir. The last question from our audience is, how do you manage and address complications such as graft rejection and infection?
So if we detect it early, that's why we train and educate the patients that they must come to us as soon as they find any disturbance in their graft, any redness, any drop in vision, because it could be infection or it could be rejection. Both of them, the vision drops, and on the phone we can't give diagnosis. I remember during a time when there was curfew and riots, a patient who stayed far away called me up to say that there is pain, redness, watering in the eye. I didn't know whether it was infection or rejection. In rejection, we give them steroid drops. In infection, we have to give antibiotic drops. So it is important that they see a local doctor. So the compliance is very important both for artificial as well as for natural corneas. So in early stages, they can be revived. Even rejection can be revived by giving the steroid drops. No need of oral steroids. But in the late stages, the patient comes late, then we have to do repeat procedure. Thank you.
Thank you, sir. Before concluding today's session, any last remark from you?
No, I just want to give this message of hope that many people feel that a corneal transplant is something which can only be, it's a very complicated thing and it will never work. And after some time, the cornea will become opaque. That is not so. My father was an eye surgeon. I've seen operation patients operated by him 50 years ago when they were children. They're coming to me for follow up with crystal cornea, clear corneas, even 50 years down the line. So natural corneal transplant is the way to go. And if not, artificial corneas offer a ray of hope for everyone who is corneally blind. So please spread this message far and wide. Thank you.
Thank you once again, sir, for joining us today and answering all our questions. Sir, with your permission, I would like to conclude today's session. Thank you.
Thank you. Thank you so much. Okay. Bye bye.